Okay, so this is kind of what we're going through today. As I said before, gastro is a huge topic. So we've picked out kind of the really important pathologies and conditions that you should know about, particularly when you're on your gastro placement. If you do have any questions, as I said, pop them on the chat as we go through each particular condition. So starting off with our first SBA, a 71-year-old woman comes to the GP complaining of difficulty swallowing, which has gotten worse over the past month or two. She has unintentionally lost 5 kilograms of weight, and she claims that she has not been feeling like eating much recently. She does not have any pain on swallowing and has a past medical history of GORD. Her BP is 100/70 and her temperature is 36.9. What is the most likely diagnosis? And you can vote using the polling system. So the majority of you have gone for answer A. So Maharsh, can we go to the next slide? Sorry. Yep, so majority of you have gone for answer A, which is correct, esophageal adenocarcinoma. But let's go through the stem of the question to work out what the important bits are. So from the Vinaya, the key points to pick out is that this is an elderly woman who is presenting with difficulty swallowing, and that's something known as dysphagia, and it's got progressively worse. So from that information, you can rule out something known as achalasia, because with this condition, from the start, you would have difficulty swallowing food and drink. So it's not something that gets progressive over time. So you can rule out achalasia from that. She also says she has unintentional weight loss. So alarm bells should be ringing. That's a red flag where you need to exclude malignancy. And this coupled with the fact that she has dysphagia, both of them are red flags for esophageal cancer. Now, as you can tell from the answer options, there's 2 different types of esophageal cancer. And in terms of picking the right answer, you could have thought, okay, epidemiologically, the most common one of those 2 is going to be esophageal adenocarcinoma. But also something in the stem of the question is that this patient has a past medical history of GORD, gastroesophageal reflux disease. So essentially it's where you've got reflux of your stomach acid coming back up from the stomach into the esophagus. And patients who have long-standing GORD, this is a risk factor for developing esophageal adenocarcinoma. So that would have given you the answer in this question. So we can move on. Next SBA. So a 39-year-old man presents to his GP with difficulty swallowing that has been occurring over the past month. He's struggling to consume food and drink, and he mentions that he sometimes feels his food coming back up after eating. Which of the following tests is most likely to be diagnostic? And again, you can answer in the poll. Okay, I'm going to close the poll. So really interesting results, actually. We've got kind of a split between A and D. So in terms of this question, looking at the stem, this young man has difficulty swallowing both food and drink. And whenever you hear that in a stem of the question, you must be thinking about achalasia. And typically, patients with achalasia get this regurgitation of food, and that's also described in the stem of the questions. So we know the diagnosis is achalasia. And in terms of the investigations you want to do, I would agree, first line investigation would be to do an upper GI endoscopy because this patient is presenting with dysphagia. And so as I mentioned before, you want to be ruling out esophageal cancer, which you would do via an upper GI endoscopy. But this question is asking you what is most likely to be the diagnostic investigation. And so from this list, it would be something known as a barium swallow. And with achalasia, you get this characteristic bird's beak appearance. So you have this tightening of this lower esophageal sphincter at the bottom, but then you get this proximal dilatation of the esophagus at the top. And when I go through what achalasia actually is, it will become apparent why you get this bird's beak appearance. So if we move on. So dysphagia, it simply means difficulty swallowing. You can move to the next slide, yep. So dysphagia simply means difficulty swallowing. And it's really important to note that this is a red flag in patients presenting with dysphagia. Dysphagia is considered esophageal cancer until proven otherwise, particularly in patients who are 55 and above. So all patients coming in with dysphagia, you're going to have to refer them via the 2-week pathway for an urgent OGD. In terms of classifying the causes of dysphagia, there are many, but I find it really easy to classify them into kind of the mechanical causes. So things like esophageal cancer, a benign stricture, pharyngeal pouch, or even like a foreign body that's stuck in the esophagus, causing it difficulty to swallow. Or you have your neuromuscular causes. So these are things like after somebody's had a stroke, or someone with achalasia, or someone with myasthenia gravis. These are all conditions that also cause difficulty swallowing. So key questions to ask a patient with a history of dysphagia, you want to ask them, was there difficulty swallowing both solids and liquids from the start? And as I said before, if the answer is yes, that's pointing towards a motility disorder such as achalasia. If the answer is no, where initially it was solids and then it progresses on to difficulty swallowing liquids, you want to suspect a stricture, either a benign or a malignant stricture, so cancer. You want to ask, is the dysphagia intermittent, so does it come and go, or is it constant and it gets worse? If it's intermittent, you want to suspect an esophageal spasm. If it's constant and it's worsening, you want to suspect cancer. You also want to ask, is it painful swallowing? And that's something known as odonophagia. And if they say yes, that's likely because there's some ulceration of the esophagus, and that could be due to malignancy, it could be due to candidiasis in those who are immunocompromised, or esophagitis. And then another really particular question you could ask is, does the neck bulge or gurgle on drinking? And if the patient says yes, that's really indicative of something known as a pharyngeal pouch. And this is more common in older men, and it's also associated with halitosis, so bad breath. So just some important questions to ask in a history. Yep, next slide. So going through what actually achalasia is, it's basically where you have this loss of peristalsis. So remember that peristalsis is those wave-like muscle contractions that move the food through the digestive tract. So you don't get these muscle-like contractions and you get food building up in your esophagus. And in achalasia, you have this failure or relaxation of your lower esophageal sphincter. And so this part of the lower end of your esophagus essentially remains constantly contracted. And this failure of relaxation will mean that food gets stuck, fails to pass on into the stomach. Achalasia, the incidence is actually quite low, and it's actually quite a rare disease, but it is a common topic that they do like to test in SBAs. And in terms of the pathophysiology, it's basically where you have this degeneration of your ganglion cells. And these ganglion cells are inhibitory, so they would normally cause relaxation. So if you've got a loss of these ganglion cells, it means that there's going to be failure of relaxation. And that's why you get the lower end of your esophagus constantly contracted. The way a patient would present with achalasia is, as I said before, dysphagia of both liquids and solids. They get this heartburn and this chest pain. They get this regurgitation of food, which can lead to a nocturnal cough. And because less food goes through the digestive tract, these patients are often malnourished and they present with weight loss as well. So your gold standard investigation to diagnose achalasia would be to do a manometry. So this is basically inserting a probe into the esophagus, and it measures the pressure. And those with achalasia would have raised pressure because the esophagus is constantly contracted. You can also do the barium swallow, which is what we had in the question, but it's not routinely done nowadays because manometry is more sensitive. But as I said before, with the barium swallow, you see that bird's beak appearance, where at the bottom, because the esophagus is contracted, you can see it's really tightened, but then at the top, you've got your dilatation of the esophagus. In terms of treatment and management, think of it in terms of conservative, medical, and surgical. That's how I like to split my treatment of different conditions. So conservative things that you can advise patients, advise them to sleep with many pillows so it would minimize the regurgitation of the food. They can eat slowly, chew their food thoroughly. Medical management of achalasia is quite limited because often a lot of these drugs have a lot of side effects, but these drugs would include things like calcium channel blockers and nitrates, which allow for smooth muscle relaxation. And then you've also got your botulinum injection, which also allows for the smooth muscle relaxation. And then in terms of surgical treatment of achalasia, you can insert a balloon endoscopically, and then that will cause dilatation of the LOS and to stretch the muscle fibers. Or you can do a laparoscopic helemyotomy, so removing the specific fibers of the esophagus that fail to relax. So I think that's achalasia covered. And can I remind everyone just to keep their microphones on mute, just so it minimizes disruption. Okay, so now moving on to esophageal cancer. It's the 6th most common cancer worldwide, and there are 2 histological subtypes. So your adenocarcinoma is the most common, and it typically occurs in the lower third of your esophagus. And that's because it tends to arise from conditions like GORD and Barrett's esophagus, which is where you've got change in your cell types of the lower third of your esophagus. So risk factors for developing adenocarcinoma, as I said, will having long-standing GORD, Barrett's esophagus, obesity, and a hiatus hernia. Your other type of esophageal cancer, which is less common than the adenocarcinoma, is your squamous cell carcinoma. And this typically occurs in the middle and upper third of your esophagus. So adenocarcinoma is the lower third, squamous cell is middle and upper third. And your squamous cell carcinoma is strongly associated with smoking, chronic alcohol abuse. It has a high prevalence in Japan, which is a really interesting fact. And something I forgot to mention before is having chronic achalasia is also a risk factor for developing the squamous cell carcinoma of your esophagus. So in terms of presentation, dysphagia, weight loss, vomiting, odonophagia, so painful swallowing, and these patients also get this cough and hoarseness. Investigation, you want to refer these patients via the 2-week pathway, and your OGD with a biopsy is your first line. And then you can stage the cancer using a CT scan of your chest, abdo, and pelvis. Treatment, in terms of treatment for esophageal cancer, the majority of patients will present with advanced disease. So around 70% of patients will have to be treated palliatively, and you're going to need an MDT input. So input from general surgeons, oncologists, palliative care team, and also nutritionists, because these patients often find it really difficult eating. So if the patient does present early, which is quite rare in esophageal cancer, you can consider surgery. So doing an esophagectomy, which is the surgical resection of the esophagus. And this procedure is known as the Ivor-Lewis type esophagectomy. So essentially what they're doing is they're removing the tumor, removing the esophagus, and also the top part of the stomach, and then they make the stomach into a tube and bring it up into the chest. So as I'm just describing that, you must be able to tell that this is a really major operation. They're going to have to open the chest cavity and the abdominal cavity. So these patients have to be fit, but with esophageal cancer patients, often they're not medically fit to undergo surgery. There's also chemotherapy, radiotherapy, and nutritional support. So I think that's esophageal cancer done. Do we have any questions so far? I can't see the chat button. Mahash.
No, there's nothing on the chat right now.
Okay, that's fine. Remember, if you... Oh, sorry, go on.
Yeah, feel free to put any questions in the chat at any point.
Yeah, if something that I said doesn't make sense, then let me know. So the second surgical treatment is your HELLER, so HELLER, myotomy. So it's basically where you're removing the specific muscle fibers that are contracted. So if we move on to liver pathologies, so if we go into the next slide. So the first thing to think about with liver pathologies is your liver function tests. And this is really important to get your head around, because when you order liver function tests, you need to know why are you ordering them and which particular liver function test are you looking at for a particular condition. So this is a really simple overview as a guide to interpreting your LFTs. I would recommend looking at Geeky Medics, which has a really comprehensive guide to interpretation. So starting off with your AST and your ALT, these tend to be grouped together because they are markers of hepatocellular damage. So essentially, any condition that causes your hepatocytes to die and burst, this will cause your AST and your ALT to be released into the circulation and the levels will rise. But in some conditions, your ALT will rise more than your AST. And so if that happens, think about ischemic liver disease, viral hepatitis, drug-induced hepatitis. So for example, from a paracetamol overdose, you will see the rise in ALT more than your AST. But if the rise in your AST is more than your ALT, that tends to be related to alcohol liver disease. So those are really good kind of distinctions to make. And then another really important thing is, say if you get your results having taken a blood test and you look at the LFTs and the ALT is in the thousands, you need to be considering, is this acute viral hepatitis? Is this a paracetamol overdose? Or is this ischemia of the liver? So something known as Budd-Chiari syndrome, it could be. And so if the ALT is in the thousands, think of those causes. Your ALP, also known as your alkaline phosphatase, that's produced by cells in the biliary tree. So ALP levels rise in any condition that causes biliary epithelial damage as a result of there being some kind of obstruction in your biliary tree. So if you have gallstones, if you have pancreatic cancer, for example. But it's also important to notice that ALP can be raised in other situations. So if you have bone diseases, if you have malignancy where you have bony mets, and also pregnancy. So if you do have a rise in ALP, don't just think it's a liver problem. Also look at those situations as well. Your gamma GT, that's also the same as your ALP, where it's seen in biliary epithelial damage, where you have biliary obstruction. But another interesting fact is your gamma GT can also rise significantly in those who have chronic alcohol abuse and in some drugs such as phenytoin. So if you have an isolated rise in your gamma GT, think about alcohol abuse. Whereas if you've got a rise in your GGT and your ALP, you're going to think, okay, this is going to be a biliary obstruction kind of picture. And then in terms of your albumin and your INR, these are really important things to look at if you want to measure the synthetic function of your liver. So your liver synthesizes albumin. And remember, that's the protein that kind of maintains the osmotic gradient in your plasma. So if you've got low levels of albumin, you're going to know, okay, the liver isn't functioning properly. Again, your liver synthesizes clotting factors, and your clotting factors 2, 7, 9, and 10. So then if you look at your INR and your prothrombin time, and if that's prolonged, again, you're going to know that there's an issue with the liver. So if a consultant ever asks you on the ward, how do we measure the synthetic function of the liver? It's really important you don't say AST, ALT, ALP, gamma GT. It's things like albumin and your INR. So that's a really important question to like kind of get right when you're on the wards. And then bilirubin, that's kind of like where they use it to quantify the degree of jaundice, which leads nicely onto our next topic. Does anyone have any questions about LFTs? I know it can be quite confusing and I've gone through it quite quickly. But like I said, if you go onto Geeky Medics, they have a really good guide to interpreting LFTs. I don't think we have any questions, so I'll move on. So jaundice is really important to remember that this isn't a diagnosis, but it's a presentation. So anyone presenting with jaundice, which is essentially yellow discoloration of somebody's skin or somebody's sclera or somebody's mucosa, you want to be thinking, why have they got jaundice? Jaundice isn't the diagnosis. And you get jaundice when you have a raised plasma bilirubin. So what bilirubin is the waste product of when red blood cells are broken down. And in terms of the different causes of jaundice, it's easier to, there's so many, but it's easier to categorize them as pre-hepatic, hepatic, and post-hepatic, so your obstructive causes. So I think it's really hard to kind of understand this table if you don't understand how bilirubin is metabolized, and it's quite an extensive pathway. I don't have time to go through it right now, but I can summarize it for you. But something I would advise is after this lecture, if you go through the bilirubin metabolism pathway and get your head around that, understanding jaundice will become much, much easier. So I'll attempt to summarize it really quickly, but I think definitely after the lecture, go through it as well. So, as I said, bilirubin is the breakdown of hemoglobin. It's the waste product. Oh, yep, it's the waste product. And this waste product of red blood cell breakdown, bilirubin, it's water insoluble. So that's something known as unconjugated. So then it's transported to the liver, and the liver's role is to conjugate the liver. So to make it, to conjugate the bilirubin, so to make it water soluble. And because it's now water soluble, it can then be ingested in part of the feces. So it gives the feces its brown color. And also some of it gets excreted via the urine as well, giving it straw colored. So when there's an issue with the liver, that means its ability to conjugate the bilirubin will be impaired, and therefore you get jaundice. But that's a really simple overview. And then in terms of prehepatic jaundice, that's where you're going to have conditions where you've got increased red blood cell breakdown. So you've got hemolysis. And so that overwhelms the liver's ability to conjugate the bilirubin. So you're going to have a buildup of your unconjugated bilirubin. And you see this in conditions like hemolytic anemia, malaria. Your hepatic jaundice is where you've got dysfunctional hepatocytes. So the liver loses its ability to conjugate the bilirubin. And you get kind of a mixed picture because it's able to conjugate some of the bilirubin, but unable to conjugate all of it. Could everyone put their microphones on mute? Sorry. Thank you. Who's got them? Maharsh, are you able to? Yeah, I think that's fine now. Sorry. And then in terms of obstructive jaundice, also known as post-hepatic jaundice, is basically where you have obstruction in your bile ducts. So you've got obstruction of biliary drainage, and you see that in gallstones, pancreatic cancer. And you get this triad of having jaundice, pale stools, and dark urine. And this is because no bile is allowed to pass out of the liver. So the conjugated bilirubin instead gets filtered straight into the urine. So it makes the urine really dark, but it's unable to pass into the stool. So your stool are really pale. So I think that's a really simple overview of these three different types of jaundices. But if you go through the bilirubin pathway, it will become much more clearer why you get unconjugated or conjugated bilirubin rise, depending on if it's prehepatic, hepatic, or posthepatic. I think we can move on to the next slide. So this leads on to SBA number 3. A 26-year-old male presented with flu-like symptoms and pain in the top right of his abdomen. On examination, you notice yellowing of his skin and sclera. He tells you that he's recently come back from a backpacking trip across Southeast Asia and returned home 2 weeks ago. He drinks around 4 units of alcohol a week and does not smoke. What's the likely diagnosis? So I think, again, another split with hepatitis C or hepatitis A. So this patient, he's a young patient, 26 years old. He's presenting with flu-like symptoms, right upper quadrant pain, and he's just come back from Southeast Asia 2 weeks ago. So these all point towards hepatitis A, because hepatitis A, it's spread fecal-orally. The incubation period is 2 to 6 weeks, so he came back 2 weeks ago. And he's come from an endemic area of where hepatitis A is prevalent, so Southeast Asia. And the fact that he has kind of, quite mild symptoms, flu-like, a bit of jaundice, right upper quadrant pain, that's very typical of hepatitis A. It wouldn't be hepatitis C because the incubation period for hepatitis C is much longer. So if he did have hepatitis C, he wouldn't have had any symptoms yet because he's only come home 2 weeks ago. And with hepatitis C, you don't tend to have symptoms straight away. You tend to get the symptoms when they've developed kind of chronic liver disease. So if we move on. So yeah, we're going to be talking about viral hepatitis now. And as the name suggests, it's basically where you have viruses causing liver inflammation, and these infect your hepatocytes. And you've got a range of Hep A all the way down to Hep E, and each of those have different characteristics, which we've summarized in this table. So Hep A tends to only cause an acute phase infection and rarely progresses on to a chronic infection. And as I said before, it's spread via fecal-oral route, or also by eating shellfish. And you tend to see Hep A in endemic areas such as Africa, Asia, South America. So if the stem of the question has something that a traveler has returned from one of these areas, can think about Hep A. It has a short incubation period of 2 to 6 weeks. So essentially, that's the time it takes between being exposed to the virus for then symptoms to become apparent. And it's quite a self-limiting and mild disease. So treatment tends to be quite supportive, like bed rest, symptom control with antiemetics and antipyretics for any fever. And yeah, as I said, it's quite self-limiting. And it's important to note that there is a vaccine available for hepatitis A. Another one that goes hand in hand with hepatitis A is hepatitis E. They both have similar features because they're spread via fecal-oral route, and again, seen in high-risk areas such as Africa and Southeast Asia. But the differences between the two is that hepatitis E has a slightly longer incubation period. There is no vaccine available for hepatitis E, and it carries a significant mortality rate if a pregnant woman develops hepatitis E. So it can lead to something known as fulminant hepatic failure, and it actually is really, really bad. So if in the stem of the question, it does have kind of a pregnant woman got hepatitis, and she then died, that's often a question. Think about hepatitis E, it's really significant in those who are pregnant. Hep B, with this, unlike Hep A, you can get acute and chronic disease, but the chronic disease, you tend to see it more in children. They're more likely to develop the chronic Hep B infection. It's a bloodborne virus, so it's transmitted via bodily fluids. So risk factors will be those who are intravenous drug users, tattoos, sex workers, and those who receive transfusions, although that's become less of an issue nowadays. It has an incubation period of around 4 to 12 weeks, and there is a Hep B vaccine. And then another one that goes along with Hep B is Hep D, because for Hep D, you need to also have Hep B, because Hep D relies on hepatitis B virus to complete its replication and transmission cycle. So a patient can only be infected with hepatitis D if they also have hepatitis B. And then the last one is hepatitis C. So again, the same with Hep B, you can get an acute and chronic infection. But unlike hepatitis B, where the chronic infection was mainly seen in children, you tend to see chronic hepatitis C infection in adults. Transmission again via bodily fluids, and there is no vaccine for Hep C. So the only two where there's a vaccine is Hep A and Hep B. On to the next slide. So this is one of the most commonest questions they like to ask in SBAs, is interpreting Hep B serology. And I think students find this really hard. I definitely found this really hard last year, but I kind of found kind of an order in which to go through it that worked for me. So I'll go through that now. So something I look at first is your hepatitis B surface antigen, so the third column. And if that's positive, you know that the patient has a hepatitis B infection of some sort currently. You don't know if it's acute, you don't know it's chronic, but you know they have some sort of infection. So the first thing I look at is your hepatitis B surface antigen. Then I look at the anti-HBC IgM, so your IgM levels. And your IgM levels is a marker of acute infection. So if your IgM level is positive and your HBS antigen is positive, you know the patient's got an acute hepatitis B infection. If, on the other hand, you look at the IgG, IgG is produced in the longer term. So if IgG is positive and your surface antigen is positive, they've got a chronic hepatitis B infection. So I'll go over that again. First, look at the surface antigen. If it's positive, you know they've got some sort of infection currently. I then look at the IgM, and if that's positive, you can tell, okay, that's an acute infection. If that's negative, I then look at the IgG. If the IgG is positive, that means they have a chronic hep B infection. And then the last thing I look at is your anti-HBs. So these basically reflect recovery or immunity. So for example, it may be positive if someone's had a hep B vaccination, or if they've previously been infected and they've developed immunity. So I hope that makes sense. So yeah, just go through it in a logical order and you'll get to the right answer if you follow that. Should we move on to the next SBA? So a 52-year-old man presents with jaundice. He has a long history of alcohol misuse, consuming over 30 units a week for over 10 years. His skin is not itching, and on examination, you see the following signs. So hopefully you guys can tell what these signs are. If not, we'll go through them in a bit. His bloods show a raised ALT and AST, low albumin, and his prothrombin time is slightly prolonged. Which of the following is the most important initial management? So the majority of you chose answer B, which is correct, but we also had a lot of people choosing spironolactone. Oh no, sorry, most of you chose answer B, which is incorrect. Answer C is correct, spironolactone. So we'll definitely go through this. So in the stem of the question, the man is presenting with jaundice. He has a significant alcohol history. And the following signs that you can see. So the first picture shows ascites, so abdominal distension. And it's basically where you have fluid entering your peritoneal cavity, causing this distension of your abdomen. And we'll go through why you get that. The second picture shows clubbing, which you see in those with chronic liver disease and cirrhosis. And then the third picture shows something known as Dupuytren's contracture, which is something you see in those with alcohol-related liver disease. That's very severe. And it's basically where you've got contracture of your palmar fascia leading to flexion of that fourth finger, as you can see. So this man has, sorry, let me just remove. So in terms of the answers, this man has cirrhosis and chronic liver disease. The answer is spironolactone, because you want to treat his ascites. So he's got all this fluid in his abdomen and you want to kind of remove that. So the way you treat ascites is by fluid restricting the patient and also using diuretics to remove the fluid. And an example of a diuretic used in the management of ascites is spironolactone. You wouldn't use cholestyramine because that's a treatment for pruritus, so itching, but it says in the history that he doesn't have any itching. You don't need a platelet infusion because we have no idea of what his platelet level is. And liver ultrasound, you would do it in chronic liver disease patients and those with cirrhosis, but you would do it every 6 months. And you do a liver ultrasound to ensure that the patient hasn't developed hepatocellular cancer. But we've asked you in this question the most important initial management, and that would be dealing with those ascites. So that's why the answer is spironolactone. If we move on to the next question. So SBA 5, a 30-year-old woman presents to her GP with itchiness of the skin in the past month. You notice that her sclera and skin are yellow and that she has several bruises on her legs. When you ask her about these, she mentions that she's noticed that she's bruising much easier this past week. Her past medical history includes type 1 diabetes and chronic hepatitis C. Which of the following is a complication of the condition that she has now developed? So the majority of you have chosen the correct answer, which is answer A, esophageal varices. A few of you have gone for hepatitis B and esophageal cancer, so we can go through that as well. So this patient has chronic hepatitis C, and that has now progressed onto liver cirrhosis. And you can tell this because it says she has chronic hep C, she's come in with jaundice, pruritus, and has several bruises as well. So in decompensated liver cirrhosis, you get something known as portal hypertension. So it's essentially where blood flowing through your hepatic portal vein, there's a backlog of it. And so then it goes up through the esophageal veins and your gastric veins. And you can develop something known as esophageal varices. So that's what's happened with this patient. And if these varices rupture, you can get an upper GI bleed, not a lower GI bleed, but we haven't got any indication that this patient's developed that. It wouldn't be esophageal cancer because the fact that she has hep C has nothing to do with esophageal cancer. Hepatitis B, it wouldn't be that because she has hep C. And actually, liver cirrhosis tends to come from chronic hep C infection rather than hepatitis B. And it wouldn't be gastric cancer because there's no kind of risk factors of gastric cancer mentioned in the STEM. So if we move on. So, I think, has the top bit gone? Okay, I'll just move on. So liver cirrhosis, it's essentially irreversible end-stage chronic liver disease. And it's basically where you have fibrosis of your hepatic tissue. So any of your liver pathologies can progress onto cirrhosis. So things like chronic alcohol abuse, chronic hepatitis C infections. There's a whole spectrum of liver conditions that you can look up that will lead on to liver cirrhosis. And there's two different forms of liver cirrhosis. You can have compensated liver cirrhosis, which basically means that yes, you have cirrhosis, but actually you have preserved synthetic liver function. So everything's fine, you don't have the complications. Or you can have decompensated liver cirrhosis. So this is where you then start getting evidence of the complications that occur with liver dysfunction. And that's what this patient presented with. You get jaundice because your liver is unable to conjugate that bilirubin, which is what we mentioned before. You get something known as Palmer erythema. So the liver usually metabolizes estrogen, but then if your liver has become so damaged because of the cirrhosis, it's unable to do this. So then you get raised estrogen levels, and that leads to reddening of your palms. So that's known as Palmer erythema. And also because you've got increased estrogen levels, you get something known as gynecomastia, so enlargement of your breast tissue. And you typically see that in male patients. You get Dupuytren's contracture, so we had a picture of that earlier, which is particularly related to alcohol-related liver disease that then progresses onto cirrhosis. Liver can't make albumin. Remember, albumin is used to maintain the osmotic gradient. So then your fluid is going to shift and you get edema. You also get clubbing and bruising as well. So something I would advise you guys to do if you're on your gastro placement is on the wards, definitely conduct abdominal examinations, because these are signs that you often see in patients. And when you know the reasons why these signs have happened, it's much easier to understand the condition. So in terms of investigations, your LFTs, which we went through before, your INR and your albumin levels to see the synthetic function of the liver. You can do something known as a fibroscan. So that essentially measures the stiffness of the liver using sound waves. And you can also do an upper endoscopy to look for the esophageal varices. And we've put a picture of the Child-Pugh score, which is basically classifies the degree of cirrhosis. So if we go on to the next slide. So I've gone through kind of like the signs that you get with cirrhosis, but one of the important things is the complications, and that's where patients often deteriorate because of liver cirrhosis. So one of the main things to understand with liver cirrhosis is this thing known as portal hypertension. And I mentioned it before, but I'll go through it again. Because the liver is so fibrotic and stiff, you're going to get increased pressure and resistance of your hepatic portal vein. So blood enters the liver via the hepatic portal vein. So if the liver is really stiff, it's going to be really hard for blood to get into the liver, so it backs up and it needs to find another way to bypass the liver. And so what it does is it goes back up through the esophageal and gastric veins that causes your esophageal varices, or you can get fluid being pushed into the peritoneal cavity, causing your ascites and your abdominal distension, or you can get blood pooling in other abdominal veins, and this causes caput medusae. And this is what you see with complications of liver cirrhosis. So your ascites, your esophageal varices, and these can go on to cause upper GI bleeds, infection such as spontaneous bacterial peritonitis. And this is what causes the deterioration of these patients. And you can also get liver failure. So the liver has so many different functions, and another one of them is to kind of break down toxic metabolites, which includes ammonia. So if you've got liver failure, ammonia is going to build up, reaches the brain, and you get this encephalopathy-like picture, and you get this typical liver flap that you get with hepatic encephalopathy as well. And those with liver cirrhosis also have an increased risk of developing hepatocellular cancer. Yeah, we can go on to the management. So management of management of liver cirrhosis tends to be kind of guided by what the patient is presenting with. If we go back one, yeah. So if they have pruritus, you can give cholestyramine. As we said, management of ascites, which is the fluid buildup, restrict fluids for patients. They should have low sodium diet, use diuretics. And then if they do have infection of that acidic fluid as well, you can give antibiotics. And you do your ultrasound every 6 months in those with cirrhosis to check for hepatocellular cancer because they have an increased risk. Yep, if we move on. And then alcoholic liver disease, I've kind of touched on this as we've gone through the presentation. But yeah, it just presents with, your right upper quadrant pain, enlargement of your liver and your spleen, so your hepatosplenomegaly, and you have a history of significant alcohol use. And as I said before, a really good way to look at if it is alcohol-related liver disease is to do your liver function tests. And if you have an AST to ALT ratio more than 2, so your AST is markedly raised in comparison to your ALT, that points towards alcoholic liver disease. And also if you have a raised gamma GT in the absence of a raised ALP, that also points towards alcoholic liver disease. And there's different ways you can manage it, like I said, with the management of cirrhosis. But another thing you can use is prednisolone as well. I'm not entirely sure about the mechanisms of how steroids can help, but a study was done and it does help. So they use it in the management as well. Next slide. So final SBA from me. A 57-year-old man presents to his GP with weight loss and right upper quadrant pain. He appears to be jaundiced and he drinks 50 units of alcohol a week for the past 7 years. He does not take any drugs. He's not had any changes in diet or bowel movements. Which of the following tests would be most useful to confirm for the diagnosis? So hopefully you guys didn't see the answer, but yeah, just vote in the poll. So most of you have gone for alpha fetoprotein, so AFP. A few have gone for prothrombin time. So we can go through that now. So this patient, it's likely that he has hepatocellular cancer. You can tell from the stem of the question because he has red flags such as weight loss, a significant alcohol history, he's got jaundice, and he's got right upper quadrant pain. So that's pain where the liver is in your abdomen. In terms of tumor markers, it's really important to learn which tumor marker goes with which cancer. So alpha fetoprotein is markedly raised in hepatocellular cancer. CA19-9 is for pancreatic cancer. CA125 is for ovarian cancer. ALP it's not very specific for LFT. As I said before, it could be raised in bone diseases and pregnancy. So it's not a very specific test. And prothrombin time, although it could be prolonged, as I said, in cirrhosis, again, it's not specific for hepatocellular cancer. So AFP is the right answer. Move on. So that leads on to hepatocellular cancer. So hepatocellular cancer, as it says by the name, it arises from your hepatocytes in your liver, which result from a chronic inflammatory process. So Hep B is the most common cause worldwide, but hepatitis C is the most common cause in Europe. And it's important to remember that Hep B, you can get chronic Hep B infection, and then it goes straight onto hepatocellular cancer, whereas the kind of trajectory for Hep C is that you get Hep C, then cirrhosis, then the cancer. So the Hep B kind of misses out the cirrhosis bit. So risk factors is cirrhosis, hemochromatosis, which we haven't gone through today, but it's basically where you have raised iron levels that then affect your liver. PBC, which Maharsh will be going over, and alpha-1 antitrypsin deficiency. Presentation, it typically presents late with symptoms of liver cirrhosis, so everything we've gone through previously. And your alpha fetoprotein is raised in around 60% of patients. And this tumor marker is also really important to use to look for if the patient has responded to treatment well, and to look for if there's any kind of recurrence once you've treated the patient. Other investigations to do is ultrasound every 6 months for high risk groups, so those with cirrhosis as well. Management, surgical resection if the patient presents with early disease, and liver transplantation if the patient meets the specific criteria. Or there's medical options, so things like ablation or a tyrosine kinase inhibitor known as sorafenib, but that's quite complex and in-depth stuff that I don't think you will need to know. Another important thing is that primary liver cancers are actually less common than metastatic liver cancers. So hepatocellular cancer is less common than, for example, another cancer metastasizing to the liver. So most often this would be bowel cancer. So it's important to bear that in mind as well. So I think that's my section of this done. Were there any particular questions that anyone came up with? If not, we can move on to the pancreatic side of gastro.
So we'll move on to our first SBA. So a 68-year-old man comes into the GP with severe abdominal pain after meals. Which he says bores through to his back. He finds that leaning forwards while sitting can sometimes relieve this. He mentions that his feces sometimes floats and has done so for several years. He tells you that he was recently diagnosed with type 2 diabetes. Based on this, based on the most likely diagnosis, which of the following is the most likely cause of these symptoms? So interestingly, most of you have gone for A, being gallstones, and it's very interesting because, in fact, it is D. So I understand what you thought: severe abdominal pain after meals, bores through straight to the back, and worse and better whilst leaning forward. So you think pancreatitis. However, bearing in mind his feces floats and has done so for several years, and he's also type 2 diabetic. So with all that being said, it's less likely to be acute pancreatitis, which is probably what most of you thought. It's more likely to be chronic. And one of the key causes is chronic alcohol abuse, rather than necessarily an acute intake, or gallstones, which are more likely to cause acute pancreatitis. Smoking, not necessarily a cause of pancreatitis. IV drug use, more likely to be hepatitis. And yeah, Hep A, nothing really indicative necessarily hepatically, but it's more pancreatically. Okay. So pancreatitis. So firstly, we'll go through acute, and the pathophysiology is generally the pancreatic enzymes, everything that breaks down your food. That's typically what also breaks down the pancreatic tissue. Now, going through the causes, get smashed. Well, the three main ones are the get, so gallstones, ethanol, and trauma. So those are probably going to be most of your cases. Then smashed, if you want to impress a consultant, you can then go through that. Somehow everyone remembers scorpion stings, but to be honest, they're super rare, and they're only scorpions in, I think, Australia anyway. But generally, that's how you remember the causes. Presentation, severe epigastric pain radiating to the back. You also have vomiting and a low-grade fever. There's also Cullen's sign, which is, as you can see in the bottom corner, It's peri-umbilical discoloration, and there's also discoloration of the flanks as well, which is grey Turner sign. And that's why sometimes it can get confused with, let's say, appendicitis. But the key investigations are your amylases and your lipases. Both will be through the roof. So I think normal range is around less than 100, less than 50. Normally they're around 3,000, so they're very high. And you straight away, you want to do a CT to assess the severity of it. And management, well, ITU in 24 hours, depending on the criteria. You need to keep them nil by mouth, but generally there isn't really a definitive management for it. It's more like you manage all their other symptoms and not any of the side effects. So typically fluids, antibiotics, morphine, antiemetics, and again, if it's very severe, you assess for ARCP and consider a surgical referral in which they'll probably remove part of the pancreas. But generally, like, it is a very, very debilitating condition, and it can be pretty scary as well. And chronic pancreatitis, so this is just like acute, it's inflammation, and it's affecting exocrine and endocrine. So if you think diabetes, then it's more likely to be chronic, whereas acute is only exocrine, it's only enzymes. 80%, so more of it's due to alcohol now, less of it's really due to gallstones. However, it's associated with autoimmune conditions as well, such as hemochromatosis and also cystic fibrosis, although not really autoimmune, and stones or a tumor as well. So your typical presentation is, again, epigastric pain. However, it's more relieved while sitting forwards, and it's typically worse around half an hour after a meal as well. And you'll also be checking for steatorrhea and diabetes, as I mentioned before as well. Typically check your fecal elastase, so that measures your exocrine, but also you want to do a CT, just check for anything on the actual pancreas itself that might be causing it. And the management is normally just enzyme supplements, analgesia, and forgot to mention there, but also manage any endocrine. So you probably want to try and treat the diabetes as well. Okay, now this is the next SBA. And so Doris, a 67-year-old woman, presents with bright red hematemesis, which has been constant for the past couple of days, along with epigastric pain and melena. She drinks a bottle of wine daily and is known to have severe liver disease. Where is the most likely location of the bleed? So I think most of you went for E, but quite a few of you went for D as well. But yeah, the correct answer is E. So the important thing to note from the question is bright red hematemesis, also epigastric pain and melena. Straight away, you're thinking it's probably going to be an upper GI bleed. Then note the fact that she drinks a bottle of wine a day and has severe liver disease. So that's very likely to indicate some form of cirrhosis, and therefore, as Sona mentioned, one major complication of this is varices, both gastric and esophageal. However, the duodenum typically does not have as much varicetic bleeding as the esophagus, which is the main place, and that's why it's probably the most likely location of the bleeding. Okay, so we'll be going through acute upper GI bleeds now. So firstly, whilst considering a GI bleed, you need to find out the location of it. So it's normally defined by the duodenojejunal junction, the DJ junction. And in terms of symptoms, like melena, so you're black, you're very foul smelling, like tar, like feces, and that's more likely to be upper GI because it's the fecal, the blood almost gets denatured by the acid and then enters into the stool and then comes out in that kind of manner. Hematemesis, again, vomiting blood, it can either be frank, so bright red, as the previous question, or it can be more coffee ground-like. So that's where, again, the blood gets denatured, gets made into a more black-like appearance, and actually looks like coffee granules. And typically, the pain is epigastric, or can even be chest as well. However, if there's a lower GI bleed, it's typically got PR bleeding, normally fresh, either mixed in with the stools or potentially on wiping. We'll cover this more in our next BIMA clinical crash course session. It's typically left iliac fossa pain or just generally lower abdominal pain. And there's not normally hematemesis either. One thing to bear in mind though, is there can be PR bleeding with an upper GI bleed as well. Often it's very sudden and then melena develops. With both, you're normally assessing for any signs or symptoms of hypovolemic shock. So dizziness, hypotension, and yeah, as I said, shock. And then you need to find out the location of the upper GI bleed and what the common causes are. So esophagus is normally varices, as well as Mallory-Weiss tears or Boerhaave syndrome, which normally happen actually on the esophageal-gastro junction, the junction between the two. So the stomach is normally perforated ulcers, also gastric varices, PHG, so which is portal hypertensive gastritis, and erosive gastritis. And finally, the duodenum, in which duodenal ulcers can also perforate as well. And those are the common ones. And when you ever think any kind of emergency management, always think A2E approach, especially in an OSCE, I'll immediately get you a point. So A, airway, again, check patency, breathing, respirate, O2 stats, ABG, etc. if needed. Circulation, this is important to this case now. So you probably want to give them large cannulae and give them fluid straight away because they'll probably will be losing blood. And want to assess also FBCs, using these as well because you want to assess the hydration, as well as a group and save if you want to give them a blood transfusion, and a coag screen because you don't know what's causing that bleed. It can also be any anticoagulants that are making it worse. D, again, just blood glucose, GCS, neurological signs, and E, exposure. You check the temperature for any infection, check the abdomen as well, palpate it, see if you see any bruising on the abdomen. Put a catheter in, something very important. Not only do you measure urine output, but you can also potentially assess for any UTIs. And finally, again, anything else that you think is reasonable will also come under E. Another thing to bear in mind is if you're thinking that it's going to be Boerhaave syndrome or also perforation, you want to perform a chest X-ray. And this is just a good infographic that I found that summarizes the difference between Mallory-Weiss syndrome and Boerhaave syndrome. And basically, Boerhaave is just an extreme Mallory-Weiss tear. So Mallory-Weiss is normally inside the actual...
Maharsh, I think the audio has cut out a bit. So yeah, maybe just
I'll move a bit closer, sorry. Can you hear me a bit better now?
Yep.
Yeah, okay, fab. So Mallory-Weiss tears, they normally happen inside the actual gastrointestinal tract, whereas Boerhaave syndrome, that normally causes a complete rupture and causes bleeding outside. And for Boerhaave syndrome, you're looking for your triad, so of chest pain, subcutaneous emphysema, and you're also looking for Hammond sign as well. So you can hear crunching sign upon auscultation as well. And again, these are Boerhaave syndrome. You want to exclude that for any GI bleed. So another SBA. After acute management in A&E involving aggressive fluid resus and an O-negative transfusion, she reports it's the same patient as last time. She reports feeling less breathless and finds her BP is 92/63 and her heart rate is 104 beats per minute. She has a history of transient ischemic attacks, osteoarthritis, and heavy drinking, which she is on clopidogrel and ibuprofen for. The blood results come back as hemoglobin 89, MCV 88, urea 10, creatinine 93, PT, prothrombin time 12, activated partial thrombin time 32. What is the next step in her management? So most of you went for B, endoscopy, with the others going through a mix of the other options, and that's right. So the key thing is she's no longer as hemodynamically unstable anymore. She's received treatment, she's less breathless, her blood pressure is actually fairly reasonable, same with her heart rate. And the important thing is you can't reverse any of her pain, any of her drugs that she's on. So clopidogrel, it normally takes 7 days before its activity actually wanes, so you can't really do much about that. Otherwise, you would, if it was warfarin, you would have given vitamin K and prothrombin complex. And looking at her blood results, she's anemic, yes, and her MCV is low. However, her MCV is normal, sorry. Therefore, that indicates more of a blood loss anemia. So iron isn't going to do anything for that. Urea is elevated, but normally, sorry, that's meant to say bleed. Normally, a bleed causes urea elevation because the red blood cells themselves, they get broken down, and then that increase in broken down red blood cells then causes a spike in urea. Okay, and also clopidogrel doesn't typically affect PT or APTT, which is another thing that's worthwhile bearing in mind. Okay, so typically management, firstly, there are 2 scores I'd say it's worthwhile just knowing about. So firstly, there's a Glasgow-Blatchford score. So this is if in GP or in an outpatient setting, you're assessing whether they need urgent hospital treatment. It's based on a load of different factors. The key things are urea, as well as the FBC, any signs of hypotensive shock, and it's generally whether they need to be admitted or not. And then there's Rockwell score, which is assessing for your severity of the bleeding. So again, that goes through a lot of the blood results, also goes through endoscopy findings after they come in. And it's worthwhile just having a more in-depth look at both of them, because unfortunately I don't have time to properly go into them. So first thing, again, stop NSAIDs and review anticoagulation. The reason why I said review is some anticoagulation, especially for prosthetic heart valve, it may be necessary. Otherwise, you're putting them at severe risk of any strokes or any adverse events. So you don't just want to stop it completely. Always look at your patient, why are they on those anticoagulants? Can you reduce the dose? Can you monitor it better? Or if you have to, fair enough, for how long and what other safeguards have you put in place so they don't get worse because of that. And again, endoscopy within 24 hours for all major upper GI bleeds. So you need to find out the cause. You can't just discharge them. So here's the treatment in the various types. So varices, terlipressin, this can typically be done in your A to E assessment. If you remotely suspect varices, you want to give it because it's a vasoconstrictor of the GI, particularly of the esophagus as well, and it can really help reduce the bleeding. And then if it's esophageal varices, you do endoscopic band ligation, and if it's gastric, it's more cryoacrylate glue to try and properly stick them together, to try and pretty much stop the bleeding and to seal off the blood vessels. And then there's the transhepatic portal shunt. That's more of a operation further down the line, but it basically diverts blood straight from the portal vein through the liver into your IVC, and therefore reduces your portal and blood pressure and will prevent varices from appearing in the future. If you've got a ruptured peptic ulcer, you typically want to endoscopically stop the bleeding. So this can often be done either through adrenaline or through cauterization as well. And also you want to do any IV, you want to give them IV PPIs as well, just to stop any further ulcer damage as well. And finally, Borhave syndrome, urgent surgical intervention. You want to ring gastro straight away and just tell them they need to do an emergency laparoscopy. Okay, so next SBA. Mr. Smith, a 49-year-old man, then presents to his GP with a 4-month history of dyspepsia, which is typically worse after eating and is worse lying down. Sometimes he finds that he needs more Gaviscon after meals and just before bed. He has also mentioned that he has lost 1 stone as he avoids eating as much food now. He is otherwise well and mentions no problem swallowing. He has a smoking history of 8 pack years and drinks 30 units a week, mainly on the weekends. What is the next step in management? And okay. Right, so most of you went for A, but I think that's very close with C and also with D as well. Right. So A is in fact the correct answer. And whilst looking at this, you need to go through quite a few of the red flag risk factors. That's why. So he's 49. He has a 4-month history of dyspepsia. It's worse whilst lying down. And he finds that he needs more Gaviscon. So he's already trying antacids and it's not really working. He's mentioned that he's lost 1 stone. He says this is because he avoids eating as much food, but you don't know that for certain. And any form of significant weight loss immediately is a red flag for, again, as we covered before, any kind of esophageal cancer or any upper GI cancer. He's otherwise well, however, and he mentions no problems in swallowing. Okay, so he's otherwise well, so you probably don't need to necessarily admit him straight away. And no problem swallowing, that's just another red flag as well. But yeah, the important thing is just remember what the red flags are, and then depending on that, treat otherwise. So I'll now go through dyspepsia, and I'll start off with the management criteria of it, because this is very important. So the emergency endoscopic criteria, so the main red flags you're looking at, they're anemia, loss of weight, anorexia, recent onset. So if it's, I forgot the exact cutoff for it, but I think it's, if you're talking about within weeks rather than within months, then you're looking at that as well. Melena, or hematemesis, indicating a GI bleed, and any swallowing difficulty, so dysphagia, and also 55 as well. Like they just plucked a number. They just plucked a number saying 55, but realistically, even around that age, you might want to consider it. But yeah, management otherwise would simply be starting off conservative. Diet and weight loss are important. Stop smoking if they are smoking. NSAID and bisphosphonates, they're the 2 biggest causes. So you might want to review that as well. Again, by review, if let's say they need NSAIDs desperately to move because their osteoarthritis, let's say the ankylosing spondylitis is so bad, you don't want to necessarily take them off it, but it's worthwhile just having a look into it and see if they need any support with that. Then after 4 weeks, if those aren't working, then you do a H. pylori breath test. So that's looking for H. pylori itself, one of the causes of dyspepsia. And then either if that's positive, you initiate triple therapy, so amoxicillin, clarithromycin, and a PPI for 4 weeks. And if it's negative, then it's just trial PPI therapy for 4 weeks. And then if it's unsuccessful, again, endoscopy. If it's successful, often you can just keep them on the PPI. So now we're looking at the inflammatory causes of dyspepsia. So important thing to differentiate between is gastritis and peptic ulcers. So gastritis is more inflammation in the gastric lining, and often it can either be because of weakness of the alkaline mucosa or just increase in strength in the acid. And often that can cause peptic ulcers, which are full erosions in the lining, and that can often be causing scarring, and it can be present across the whole upper GI, whereas gastritis, by definition, is just in the stomach. Common symptoms, epigastric pain. If it's worse after food, immediately after food, then it's gastric. However, if it's better after food, it's duodenal. The reason why is because if it's duodenal, then as soon as food enters the stomach, there's a gastroduodenal reflex that then causes all the acidic contents of the duodenum to then be pushed along. So there's actually a increase in the pH of the duodenum there, and there's less acid attack, which relieves the symptoms. But then it comes on a lot worse around 2 to 3 hours after eating. Whereas gastric, again, as soon as food enters, stomach acid increases, pH decreases, and it normally feels a lot worse as well. Along with this, often nausea and vomiting can be symptoms, and some weight changes can be present, though, as I mentioned before, it's important to differentiate that from any cancerous and more insidious cause as well. And the two main causes of both of these are NSAIDs and H. pylori infection. But however, there's also bisphosphonates, smoking, and stress. Those are like a few other big causes as well. But I think it's 80% or something are caused by NSAIDs and H. pylori. And GORD and hiatus hernia. So GORD is a very, very common illness. I think I'd even say that most people over 50, I think, do have or have had some form of GORD at some point. So this is where acid from the stomach enters the esophagus and causes a bit of irritation. So typically the presentation is worse whilst lying down, or after meals as well. Often there can be a cough as well associated with it, bad breath, and if it's really severe, it can cause dysphagia as well. And as I mentioned before, dyspepsia is a big thing. So risk factors, obesity, caffeine, and spicy foods. We're not sure why spicy foods, but there is some link between that. It can also be hereditary and often increases with age, and hiatus hernia is a very big risk factor as well for it. Typically, the main treatment would just be an 8-week PPI trial. If you think it's just GORD and you don't, and there are no other insidious symptoms alongside that. And if that's not successful, then again, just endoscopy, check out what the cause is, or check out if it could be anything else. Hiatus hernias, this is where basically part of the stomach herniates, so goes up through the gastroesophageal junction, goes up the diaphragm pretty much, into the chest. So the two types, sliding is by far the most common, and that's where the actual junction itself moves up. So because of that, it causes you to be more symptomatic, because there's nothing stopping the acidic, the acid secretions from going up through the esophagus. Whereas rolling, that's more a separate part of the stomach, herniates through the diaphragm, and that's typically less symptomatic. Your treatment is largely conservative because often a lot of people have it but don't know it until it's actually investigated. However, if it's very severe, or if it's associated with other serious conditions such as gastric cancer, then you typically want to perform surgery. And this is done by Nissen fundoplication, but there are now newer techniques. However, I still think most SBAs, it'll probably be Nissen fundoplication. That's the main surgery they still have. And as I mentioned, gastric cancers. So firstly, there's the most common type, which is the adenocarcinoma of the stomach, and normally you see signet ring cells. It'll be worthwhile just having a quick Google as to what they look like. But honestly, if you're like me, it probably won't make that much of a difference. It'll still be tough to recognize it. But I'm just terrible with histology. Risk factors: peptic ulcer disease, GORD, and smoking, as well as it's also got a hereditary link, as with quite a lot of GI cancers. Typically, your signs and symptoms are epigastric pain, and you can also feel an epigastric mass, and weight loss, nausea, vomiting. And here's a common OSCE sign you need to look for, which is Virchow's lymphadenopathy. So this is a lymph node which is on the supraclavicular area. And just wondering, can everyone still hear me?
I think it's muffling out, so maybe sit closer.
I'm not sure what else I can do really.
It's fine now.
Yeah. Okay.
Yeah, I can let you know if it happens again.
Yeah, I'll try and speak a bit louder, but I'm terribly sorry.
No. Yeah, that's fine.
Okay, that's fine. Yeah. Right. So investigation, it's typically endoscopy and biopsy, as with any cancer, you want to biopsy it. And then a CT, thorax, abdomen, pelvis, you're looking for any metastases. Management, well, is either surgical approach, if it's not too bad, so gastrectomy, and chemoradiotherapy in an adjuvant approach. However, if it's more severe, there's probably going to be more palliative, and maybe less keen on surgery as well if they're not fit. But what's important is an MDT decision, and that's the main thing that you'd adopt. So that's the thing you should probably mention in an auscultation, just MDT approach. And now there's another type of gastric tumor called Zollinger-Ellison syndrome. And this is a neuroendocrine tumor. So this secretes a hormone called gastrin, and that's what normally causes acid secretion in your stomach. And it's just overproducing this hormone. So presentation is normally dyspepsia, peptic ulcer disease, GORD, but the key thing is typically unresponsive to treatment. So your investigation is actually normally fasting gastrin levels, and this is just a simple blood test. However, you'd probably want to perform an endoscopy as well, so you can properly visualize a tumor as well and get biopsies, etc. Management is typically surgery and then long-term PPI as well, just to try and stop the symptoms. Okay, so now moving on to our next SBA. So Mr. Smith's endoscopy, again, this is the same patient, finds no gastric pathologies and his symptoms are likely attributed to GORD. However, there is noticeable metaplasia of the lower esophageal mucosa, showing simple columnar cells and goblet cells. He is prescribed lansoprazole to help with the symptoms. What other management would you offer Mr. Smith? Okay, so most of you went for C, however, a lot of you also went for B. And the correct answer is indeed C. Again, no gastric pathologies, however, there's metaplasia of the lower esophageal mucosa and it's simple columnar, and goblet. So you're thinking this is probably going to be Barrett's esophagus, right? And it's a histological diagnosis. Whilst he's already been given a PPI to try and alleviate any further risk, the key question is, what do you then do about it? Because it's metaplasia and not dysplasia, you actually don't have to remove it. You can just simply review it endoscopically. There is a new thing in management now saying that some of it can actually be managed by ablation. However, that's a very new treatment that's being considered, and even so, you certainly wouldn't perform any resection of it, if that makes sense. You might try and ablate it, but you wouldn't try and fully remove the mucosa if it's only metaplasia as well. And yeah, you'd probably review around every 3 to 5 years. Okay, so Barrett's is by definition, again, esophageal epithelial metaplasia, and it's caused by chronic esophagitis. So basically inflammation of the esophagus, nearly always is due to GORD. Histological changes, it's typically a stratified squamous, so that's the normal epithelium of the esophagus, and it changes to simple columnar. It can either resemble the cardiac region of the stomach or the small intestine, in which there'd just be more goblet cells if it looks more like the small intestine. Risk factors are, GORD, the biggest one. Also, it's more common in males, smoking, and again, obesity, because smoking and obesity, risk factors of GORD as well. It significantly increases your risk of esophageal and adenocarcinoma. I think it's around 50 times or something. So it's very big. Management, again, regular endoscopies every 3 to 5 years. You want to give them long-term PPIs. And if there's any dysplasia, you want to then remove it. So the difference, I think, between metaplasia and dysplasia is metaplasia is cellular changes that increase your risk. However, dysplasia is something that's very precancerous, and pretty much if you don't do anything right away, could probably turn to cancer very, very quickly. Again, that's not a full histological definition, but that's clinically, that's what it means. So high-grade dysplasia, again, radio frequency ablation, you just want to get rid of it. If there's a specific nodule, then you want to like manually resect it, well, endoscopically, but you want to manually like cut it all out. And then if it's very severe, you probably consider an esophagectomy, so try and actually remove the esophagus. But that's got a load of complications to it and will very severely impact their life. So it's something that's difficult to balance. So the next SBA. Mrs. Williams, a 43-year-old housewife, presents into A&E complaining of right upper quadrant pain that has been present since her last pregnancy 3 years ago, but has increased in severity in the past 2 days. She noticed her previous pain was worse at night and was best first thing in the morning. She drinks 20 units a week. On examination, she is tender in her right upper quadrant, especially upon palpation whilst she inhales. A and B. Okay. So, as you said, as you guys found out, it was cholecystitis. So typically looking through the risk factors, she's female, she's 43 years old, and she's got right upper quadrant pain, present since her last pregnancy as well. So she has gone through a pregnancy. It's increased in severity very recently, though, in the past 2 days. Previously, her pain was worse at night and best in the morning, and she has a moderate alcohol intake, but nothing ridiculously severe. It's the tenderness, it's especially worse upon palpation while she inhales. So that's Murphy's sign and it's positive. And from her obs, again, the key thing is her temperature is 37.9 degrees. And so therefore that would probably indicate it's more of a cholecystitis picture. Whereas with pancreatitis, the pain is normally epigastric pain. And the key thing is, again, Murphy's sign is very specific to cholecystitis. Same thing with acute hepatitis. It's more suggestive of a biliary picture, particularly if it's postprandial pain. Primary biliary cirrhosis, there's no jaundice, so it's unlikely it's necessarily going to be that. And there isn't normally that much pain. And acute appendicitis, again, it's more right iliac fossa pain. Okay. So we're looking at gallstones now. And again, very common presentation as well. There are several key definitions to go through. So cholelithiasis, so that's gallstones in the gallbladder. And then cholelithiasis, that's gallstone that in the actual bile duct itself. Biliary colic, they're gallstones blocking your cystic duct. And I'll show you in the next slide, particularly the anatomy, just so you can better visualize it as well. And cholecystitis, that's inflammation of the gallbladder, and the main cause of that is going to be a blockage of the cystic duct. So biliary colic is a big cause of cholecystitis. And stones, they're mainly cholesterol. And the reason why this is important is that they are radio opaque. So typically on X-ray and CT, you're not really going to be able to visualize them that well. And the risk factors, the 6 Fs. Admittedly, I do apologize, it's probably not the most, probably not the most respectful terms, but they are very memorable and it's used in medical textbooks and everywhere. But it's obesity, again, having previous pregnancies or being pregnant, female, being in the, they say 40s, but it's around 30 to 50. Fat family with a family history, and it's typically associated with being Caucasian. The reason why most of these risk factors are there is that cholesterol secretion and therefore gallstone formation is largely associated with estrogen. And most of these, they cause an increase in estrogen. So obesity from fatty tissue, and being fertile, again, pregnancies tend to increase systemic estrogen. Females, they have more estrogen. Being around your 40s, so this is pre-menopausal, so they still have high estrogen. And finally, a family history, as with many things, and somehow associated with being Caucasian. Okay, so I put this slide in just so you can better visualize what you're looking at. So you firstly have your cystic duct, which is the bit in yellow on the right that you can see. And then you've got your common hepatic duct coming straight from the liver. And then both of these merge to form the common bile duct. And then that merges with the pancreatic duct to then go into the duodenum at the ampulla vata where they join, and then the sphincter of Oddi where they enter the duodenum. Why this is important? Depending on where the gallstone is, they cause very different symptoms. So we've already gone through cholecystitis. However, sphincters further down in the common bile duct, they can normally cause ascending cholangitis, which we'll get onto, and a sphincter at the ampulla of vata that will cause pancreatitis as well. And on the left, they're just the causes of gallstones. Nothing you need to go into too much depth, but I find it's pretty useful. So there's three main things. So increase in cholesterol secretion. Then afterwards, there's hypomotility. So the bile doesn't move that much. And then finally, there's nucleating factors. So these are things such as increases in white cells, and then also other things like previous infections as well. And then they then form these stones, which can then move and get lodged at various parts of the biliary tree. Okay, so with biliary colic and cholecystitis, I group them both together because their treatment and their management is fairly similar. However, you just need to be more on it for cholecystitis. So I mentioned before, blockage, infection of static bile is cholecystitis. That can then travel to the gallbladder, and then that causes gallbladder symptoms, and it can cause sepsis if not treated. So typically, as I mentioned before, it's right upper quadrant pain and lasts around half an hour. And then if there's pyrexia and Murphy sign, then it's more likely to be cholecystitis. There is a scoring system called the Tokyo score. I've summarized it briefly there, but if it's 1, like you barely like see any signs or symptoms for cholecystitis. And if you're 3, then you're thinking, all right, admit straight away and treat them as soon as possible as well. And it's sepsis. And then 2 is the middle ground, in which they're fairly symptomatic, but they're not like urgent, like they're going to die kind of thing. So investigations, firstly, you want to do your bloods, and the key bloods are your FBC, checking for infection markers there, LFTs, so you're looking for your bilirubin and your liver enzymes as to whether it's a hepatic or biliary cause and whether there's any jaundice. And lipase and amylase, you want to exclude pancreatitis. If you think it's likely they have cholecystitis, do lactate and cultures, because you just want to check the progression of their infection. Imaging, it's normally ultrasound scan if cholecystatic, and again MRCP if you can't really see it. Like sometimes you can do a CT, and it can show a bit of dilatation. However, I think more and more now they're starting to go away from that, because as I said, you can't really see the gallstones themselves. Management, so if it's only biliary colic and if it's asymptomatic, then you can conservatively manage it quite often, and manage the risk factors as well, such as, again, diet, such as obesity and and even stress as well. Like that can often be one precipitating sign, if that makes sense. If it's Tokyo 1 or 2, antibiotics, analgesia, and then you can perform a cholecystectomy at some point in the future. Like it can be planned operation. If it's Tokyo 3, sepsis 6. So again, I'll just briefly go through that. So it's give 3, so you give them fluids, antibiotics, and oxygen if they're below 94% saturation. And you take 3, take their lactate, you take their urine output, and also you take their blood cultures. Then you perform a percutaneous cholecystotomy. So that's where you push a needle into the gallbladder and you drain any abscess, or you can even drain the actual gallstones themselves. And that's if there's any signs that need draining. Yeah, and I just got a question. Would you not get jaundice in cholecystitis? You can do, however, as you can see, often it's a cystic duct blockage. So there's still the common hepatic duct that can still supply bile, if that makes sense. So you still get bilirubin flow into your feces. It's only one part of your bilirubin flow that's been obstructed, if that makes sense. And often there's a high threshold before you do tend to develop jaundice. Yeah. Okay. And when you've managed to stabilize them, then you laparoscopic cholecystectomy. Apologies, I just need to charge my laptop. Okay, next SBA. So a few hours after being admitted and given initial antibiotic treatment, again, same patient as before, Mrs. Williams reported that her right upper quadrant pain was worsening alongside pale stools and a yellow tinge to her eyes. Some of her blood results came back as a white cell count of 14, a bilirubin of 92, AST 42, ALP 217. What is the most appropriate next step in management? So most of you went for A, though a large amount of you also went for C. So the correct answer was A. And the key thing here is, well, firstly, she does have pale stools and she has a yellow tinge to her eyes. So that indicates jaundice. Upon looking at her blood results, again, she has a raised AST, but a substantially raised ALP. And as Sona mentioned before, that's most likely to indicate a post-hepatic jaundice picture or an obstructive jaundice picture. And also her white cells are mildly raised as well, indicating some infection. The key thing is that already we think the likely diagnosis is probably going to be ascending cholangitis. And ERCP is both a diagnostic and a diagnostic test, as well as a form of treatment for it. So if you suspect it highly, you might as well just go for it and do it without needing any further investigation there. And the other main thing is, whilst an urgent, whilst a cholecystectomy would be useful and would be required at some point, however, right now, removing the gallbladder is not going to help the symptoms because the entire bile duct is blocked. You need to relieve that blockage as soon as you can, and then allow the bilirubin to start flowing. That is probably your main priority. Then afterwards, you would then stabilize them, consider their risk factors, and again, remove their gallbladder to try and reduce the risk of having further gallstones. Okay. So ascending cholangitis. Again, the main cause is gallstones. However, there is also biliary trauma, chronic pancreatitis, sclerosing cholangitis, which we'll get onto, and any form of malignancy as well that can block the common bile duct, particularly from the head of the pancreas as well. So your signs and symptoms, so Charcot's triad, so that's right upper quadrant pain, pyrexia, and jaundice. if you see those three signs in someone, the first thing you probably want to think is ascending cholangitis. There's also pruritus, which is your jaundice itch. Again, epigastric pain can also be there if there's pancreatitis due to ampulla obstruction. There's nausea and vomiting as well, and often there can be pale stools due to your low fecal bilirubin. Your investigations you want to do, most important one is going to be your LFTs, because not only do they tell you what's causing the jaundice, and they can also tell you the severity of it as well, and how your liver's doing as well. Infection markers, yeah, because they're probably going to have an infection. Pancreatic enzymes, you need to exclude pancreatitis as well. Coag screen, that's normally done to as well assess your acute hepatic status. So as Sona mentioned before, normally your coag screen is your best indicator of any acute liver failure. In terms of imaging, again, ERCP, if it's the most likely diagnosis, just do it. Just do that straight away, and then you can also treat. If you're unsure, ultrasound abdomen, especially if you're unsure where the gallstone might be. And MRCP, if you don't really see much on ultrasound, but you don't really have any other clear picture as to what could be causing it. So management, it's strong analgesia, antibiotics, and sepsis 6. Sepsis 6 assessment anyway. Then there's ERCP, again, as I said before. Then you want to do a laparoscopic choledochotomy. So that's if the ERCP is unsuccessful, then you can also go in laparoscopically and then try and remove it that way. However, it's more invasive and can cause more biliary trauma. But that's if the ERCPs are unsuccessful. And cholecystectomy, that's to be arranged if it's gallstone caused, just because you want to reduce your risk of future episodes. Okay, and finally, I've put this slide in just to differentiate between two very similar sounding and also fairly similar presenting biliary conditions. So there's primary biliary cirrhosis and primary sclerosing cholangitis. So key things, PBC, it mainly affects women, whereas PSC mainly affects men. And normally they're older when they have PBC. And whilst the PSC is more progressive jaundice, there's also more fatigue and pruritus in PBC, as well as more cholestasis. So in terms of the actual cause of both of these, PBC is mainly due to inflammation of the intrahepatic bile duct. So it's where in the liver itself, there's typically an attack on the epithelia of the bile ducts. And it's normally caused by anti-mitochondrial antibodies, so AMAs, and specifically anti-pyruvate dehydrogenase antibodies. However, with PSC, it's more fibrosis of the bile ducts. It can be both intra and extrahepatic. So it can be inside and outside the liver. And and there are several different causes for that. That's more like one common cause is ulcerative colitis. However, PBC is largely autoimmune. And your main complications with both the cirrhosis, however, PSC is also cancer. And normally PSC is the worst one to have because it's harder to treat and it's a lot more severe. And unfortunately, it didn't seem to come through when I wrote about the management. But PBC, it's normally urodeoxy cholecystine, I think, yeah. But basically, it's a bile acid analog, and what that does is not only does it decrease the actual cholesterol secretions, leading to it being less likely for the biliary tree to get blocked, but it also enables better flow of bile, and therefore decreases your symptoms and can often help alleviate any of the significant effects as well. On top of that, with both, you want to be monitoring hepatic function, and if it gets severe, the main treatment is a liver transplant. With PSC, it's more of a symptomatic treatment rather than a definitive treatment, but that's also any antipyretic treatments, and they just help manage the severe pruritus as well. Yep, and that's it. Okay, thank you very much for attending the session.